This conference will now be recorded.
Welcome in, everybody. We are going to be talking about airway management in this section, which is Chapter 10 in your textbooks. The objectives that we're going to be utilizing is airway assessments, ensuring that patent airway, utilizing airway adjuncts. So we're going to be talking about just basic airway adjuncts at this point. And then on Monday, we are also going to be utilizing some advanced airways. Assessing for adequate breathing, assisting those ventilations, and then using oxygen as a therapy. So first, we're going to talk about airway assessment. So we approach our patient. First thing that we're going to do is look for airway patency, which is going to refer to whether that airway is actually open or not, and if that patient is able to breathe properly. So here, patient who is unresponsive, if they're not put into a proper position, we can see how that tongue blocks that patient's airway. So with that airway, air is going to come in through the trachea and then down in the lungs. So we can see this tongue being positioned here. That's going to eliminate that. This EMS provider is opening up that patient's airway so that when they do breathe, that air is coming in and then into the trachea and then down into the lungs. So different things that can block the airway. First, we have those obstructions from choking. We have different disease processes that I mentioned earlier within chapter 8 when we were talking about pathophysiology. Again, they relate to croup, epiglottitis, COPD, asthma, pneumonia, and we'll dive deeper into those respiratory disease processes once we reach that chapter. So when we are assessing that airway, another thing that we can look for to see whether it's properly patent or not is if they are making any sounds. So for all of us who are breathing right now, we shouldn't really hear us breathe necessarily. Now, when we approach our patient and we hear goofy, abnormal airway sounds, that is an indication that there is some type of blockage at that point. So the first one, and very common that we can hear, is snoring, which is going to be an upper airway sound in which the upper airway is partially obstructed by the tongue or by relaxed tissues in the pharynx. So a lot of individuals who are a little bit larger or have a different airway anatomy, you can hear them snoring once they fall asleep because everything relaxes. So those tissues in the pharynx actually relax. Another thing that we can hear is crowing, sound like a crow cawing. This is going to occur when the muscles around the larynx spasm and then also narrow. When we hear gurgling respirations, oftentimes this is associated with some type of fluid inside that patient's airway. And then stridor, this is going to be a harsh, high-pitched sound heard during inspiration. So for opening up that patient's mouth to assess what's going on inside, we're going to use what's called the cross finger technique. So we're going to cross our thumb and our forefinger. We're going to place our thumb on the lower teeth and the four fingers on the upper teeth. And then we're going to use a finger snap motion. And then we're going to go ahead and open up that patient's airway. So you can see how that is easily utilized. Before we actually do this, we want to make sure that we do a good proper assessment of mental status for that patient. We want to determine that they are completely unresponsive before we put our digits inside that mouth. In the event that they bite down, then we can lose a finger or two. So doing a good sternal rub. Another thing that you can do is take your fingers and brush them against the patient's eyelashes to see if they have any type of motor movement at all. So then the mouth is open, we can open up that patient's airway as well. And there are two different techniques that we can do in order to utilize this. One is the head tilt chin lift, we are going to utilize this in the event that we don't suspect any type of C-spine injury. We're going to place one hand on the patient's forehead, the other underneath the chin. Pay attention that you are only maintaining your fingers on the bony part of the jaw. So then you're going to lift up on the chin, push down on that patient's forehead, and that way you're going to open up that patient's airway, removing the tongue away from that oronasopharynx area. Now, for our patients who do have some type of C-spine injury, or we suspect that they have a C-spine injury, what we're going to do is utilize the jaw thrust maneuver. We use this because we can maintain the inline neutral position of that patient's spine. So what we're going to do is we're going to grasp the jaw with both hands, lift up on the jaw while maintaining that patient's C-spine control. So here we can see a picture of the head tilt chin lift. And then this is where we are utilizing that jaw thrust maneuver for those patients with C-spine precautions. Our patient positioning. So if we are aggressively working on the airway, we should have that patient in that supine position because that's going to be the easiest access and best technique in order to assist any type of ventilations. Now, if they are breathing on their own, if they're coming out of a seizure, what have you, and maybe their airway needs to be suctioned, then we are going to put that patient into a recovery position. So right lateral recumbent, left lateral recumbent. We can utilize gravity as our friend on this, have that patient's mouth hang out lower, and then we can suction and remove any excess vomitus and secretions from that patient's airway until we can maintain a good, proper, patent airway. So with suctioning, a couple of different pieces of equipment that we can utilize for this. We have mounted suction devices. These are going to be fixed and installed on the ambulance. We can also use portable suction devices. These are going to be electronic suction units, which are handheld, and they can create a pressure of in between 80 to 120. So here's an example of the mounted suction unit, and they almost always are located right here within the ambulance compartment. So this chair oftentimes is referred to as the airway chair. So you can assist ventilations from this point and then also suction. Oftentimes they will have large suction canisters. Everything you suction will then be placed into this canister. Once that call is completed, you will go ahead and remove and throw away that entire canister, that suction tubing, and then also your suction tip. Next, these are a couple of examples of the portable suction units. These are Laerdal or LCSU4s. So very nice suction devices. They are portable, and oftentimes they'll have a little bit smaller canisters than you would see on a mounted suction unit. So if you're working an aggressive call, heavy amount of vomit and secretions, and these canisters are starting to fill up, what you can simply do is remove it, dump it on the ground, and then replace it. Also, on these suction units, there is a dial that you can increase and or decrease that pressure. So with our infants and our pediatrics, it's always best practice to dial down the amount of pressure because we can trigger what's called the vasovagal response, and we could actually drop the heart rate and drop the blood pressure of your patients. So that's going to get into another component that we talk about as far as suctioning techniques. Another piece of equipment that we can utilize, these are called the VVAC suction canisters. So these are going to be handheld, manual driven suction devices. They do work, they just don't work extremely well. In order to create suction, you have to compress that suction handle and then withdraw that fluid or that vomitus away from that patient's mouth. So they come with an attachment, which you can see located on the bottom. So this attachment will actually go on the tip of your suction canister, and then you can put in smaller French suction catheter tips to that. Because if you're trying to suction out an infant's airway with a VVAC, then this suction tip right here is going to be really large for that patient. So the different kinds of suction catheters that we're going to utilize as EMS providers. First is going to be our Yoncourt tip or our hard rigid catheter. So this is going to be that rigid plastic tube. Oftentimes these are already going to be attached to our mounted suction units and our portable suction units, and then they'll be in play too for our VVACs. Now for our smaller patients, or if we have an airway adjunct located inside that patient and we don't have enough room to maneuver that hard rigid catheter, what we're going to utilize is a soft catheter or a French. So this is going to be flexible tubing, and they come into a variety of different sizes. Oftentimes they're going to go in between the sizes of about a 6 French all the way to a 20 French catheter. So this is a picture of what that Yoncourt tip looks like. So these Yoncourt tips have a small suction port on them. In order to actually create suction, you're going to cover up this port with your finger, and as a result, that pressure is going to draw out of the tip. Now, when you don't have a finger on that, all of that air and all of that pressure is escaping out of that port. Here's an example of that French suction catheter. So in order to utilize this, you're going to remove your Yoncourt tip from the suction tubing, and then this port here is going to be slid into that suction tubing. This is going to be your tip where you actually insert it in that patient's nose or mouth. And then in order to create suction, you're going to take your finger and then just cover up this port here, which is going to direct all of that pressure then to come out of that suction tubing tip. So how we measure for soft suction? Two different techniques how we measure. One is going to be for the nose, one is going to be for the mouth. So when we are suctioning the nasopharyngeal area or the nose area, we're going to measure from the tip of the nose to the tip of the ear. And that's how far we should insert that soft suction catheter when we are measuring. Now, when we're suctioning the oropharyngeal airway, we are then going to measure from the corner of the mouth to the patient's tip of their ear or the angle of that patient's jaw. Now, a couple of techniques for suctioning. We never want to suction for longer than 10 to 15 seconds without providing some type of oxygen therapy. And then we always suction on the way out. So we insert whether our Yoncourt tip or our French suction tip to the proper depth, and then apply our finger to that port. And then we're going to gently withdraw when we are removing that suction catheter. Now, airway adjuncts that we can utilize. We can utilize an oropharyngeal airway, a nasopharyngeal airway, or depending on our protocols and guidelines, we can also use a supraglottic airway, which is going to be our advanced airways, whether it's a combi tube, an iGel, or a King airway. But first, we'll talk about the oropharyngeal airway. It's a semicircular device, usually hard plastic, and it's going to hold the tongue away from the back of the patient's airway, inserted into the mouth. The other basic airway adjunct that we're going to utilize is the nasopharyngeal airway. So this is going to be a curved, hollow tube of soft plastic or rubber with a flange or a flare at the top end and a bevel at the distal end. So this is going to be inserted through the nose, and this is going to hold the tongue away from the back of the patient's airway. So both of these adjuncts do the exact same thing. However, they're inserted in a different manner, And oftentimes our oral pharyngeal airway is going to provide a better traction to hold that tongue away than our nasopharyngeal airway. So here's a picture of our oral pharyngeal airway. Comes in a variety of different sizes, makes, and models. All of the oral pharyngeal airways are either hollow, that you can suction out the middle of them, or they have not serrated edges, but they have grooves on the side so that you can suction down the grooves as well. How that oral pharyngeal airway is going to sit inside that patient's mouth. Again, it's got to be properly sized when you insert it so it holds it properly. Because if you are too small, that oropharyngeal is going to sit right here, and it's not going to completely block that tongue. Now, if you overestimate that oropharyngeal airway, it could sit down here, and again, that's going to block the trachea from air actually getting into the lungs. Nasopharyngeal, it's going to sit like this. So a couple of different points. The tip of the nasopharyngeal airway is going to be up here. So the most distal portion is going to be considered the tip. This cutoff section right here, this is going to be considered the bevel. So when we're inserting this, the bevel always goes towards the septum. Just like our oropharyngeal airways, there's a variety of different sizes, makes, and manufacturers. And this is how it's going to sit inside of that patient's nasal cavity, leading down into that nasopharynx airway. So how we measure for the oral airway, we are going to measure very similar to that when we're measuring for the suction tubuline with our French suction catheter. That's going to be the corner of the mouth to either the angle of the jaw or the patient's ear. So whatever you feel more comfortable with or whatever you prefer, that's how we're going to utilize that. Now, how we insert this. So ensure a patent airway. So if it is not patent, utilize your head thrust, head tilt chin maneuver, or using your jaw thrust maneuver. Open up that patient's airway. Start with that oral airway upside down and insert. When that airway touches the back of the mouth or that soft palate, rotate it 180 degrees and continue to insert until it rests on the teeth. So there, we're measuring, so corner of the mouth to the angle of the jaw. And I will demonstrate this too when we meet for lab session. Contraindications for our oral airway in the event that they have an intact gag reflex or a heavy amount of facial trauma where we can't actually visualize that patient's airway when we're inserting it. Those are going to be our two contraindications. Now, again, we should be utilizing a good sternal rub or checking for that mental status prior to attempting to insert any type of oral airway. Always have suction readily available and be prepared in the event that they do still have that intact gag reflex, that we can simply position them on their right or left recovery position so that that can help facilitate getting those secretions and that vomit out of that patient's airway. Now for nasal airway measurement and insertion, we're going to measure from the tip of the nose to the angle of the jaw or the ear. Ensure that patent airway when we're inserting. Ensure proper size. So for our oral airway, we don't have to apply any type of lubricant. For the nasal airway, we do. So choose the largest nostril, or I always like to try and insert into the right nostril first, because again, we apply that bevel towards the septum. So if I go into the right nostril, I can basically go in anatomically correct once I lubricate my nasal airway and gently slide it in until that flange or that top is going to rest against that patient's nostril. Now, if I go into the left nostril, again, I have to insert it with the bevel towards the septum. I'm going to start where it's completely inverted. I'm going to insert. Once I pass that septum portion of the patient's nostril, I'm going to rotate it 180 degrees and continue to insert that nasal airway. So this is how we measure, utilizing the tip of the nose to the ear. Contraindications that we're looking for as far as nasal airway insertion is any type of suspected fracture of the base of the skull or severe facial trauma where we can't actually utilize that. So from here, we're going to start talking about our assessment of our breathing and our ventilation. So the assessment of breathing, kind of like our cardiac output, this is the fun formula that we can utilize. However, for us in the pre-hospital field, you can't really measure proper minute volume because you're not going to get the exact tidal volume that a patient's actually inspirating. But this is how it shows up in textbooks and tests. So our minute volume is going to be our tidal volume times our respiratory rate. Our normal respiratory rate for our adult patients is going to be about 12 to 20 breaths per minute. Our normal tidal volume is going to be about 500 milliliters of air. So taking those two numbers into effect when we find our minute volume, so our normal minute volume when we take 12 respiratory rate times 500 milliliters for our tidal volume, that's going to be about 6,000 milliliters for our minute volume. Now diving deeper into our alveolar ventilation, this is going to be the amount of air that's breathed in that actually reaches the alveoli. Because with the size of our lung capacity, there is going to be areas within our lungs that no gas exchange takes place. That's going to be referred to as our dead space. So usually about a third of the tidal volume is in the dead space, and so there's no gas exchange taking place. So about 150 milliliters of air is not going to create any type of perfusion in that patient because basically it's trapped in that dead space of that patient's lung volume. So in order to figure out alveolar ventilation, we're going to take our tidal volume minus our dead air space times our respiratory rate. So again, in order to find our dead air space, it's going to be a third of the tidal volume. So if we look at this, our minute volume is going to be 8 times 300 milliliters, and that's going to be our minute volume. And then in order to find our alveolar ventilation, we are going to take 300 minus 150 and then multiply that by 8. Again, one of those things where the textbook really likes to go over. It is a good fundamental process as far as recognizing the basics, but when you're out in the field, you're going to be looking at your patient, listening to your patient, assessing that adequate chest rise, because that's going to be the key indicator whether you're getting proper tidal volume. And then as far as when you're looking at your alveolar ventilation, what is that patient's skin condition? Are they showing signs of cyanosis, where you got that blue colored around the lips and the finger beds, which means that they have a deoxygenation inside the system, or are they pink, warm, and dry? So when we're assessing for adequate breathing, we're looking for that chest rise, falling, and rising. We should see it at a regular interval. And then also look at the nostrils and mouth to make sure that they're not either gulping for air or they don't have that nasal flaring where they're really trying to drive air inside their lungs. Listen to that patient speak. So if they're able to speak in full sentences, chances are they're probably getting a pretty good volume of air at this point. Now, if they can only speak in 2 to 3 word sentences, oftentimes they need an additional amount of oxygen, additional amount of air in order to actually voice what's going on with them. You can also feel for that patient's chest and listen with your ear to determine that volume. Now be cognizant of our female patients and proper handling when you are assessing their chest. Then, using our stethoscope, we're going to oscillate over all of those lung fields to see if we can hear air passing adequately, and then also be listening for any type of abnormal sounds, such as rails, crackles, stridor, what have you. And we'll be able to listen to those different lung sounds utilizing SimMan when we meet for lab. But this is the recommendations as far as how we oscillate those lung sounds. So we start with the front of the patient's chest, right around a little bit more central than mid-clavicular, and then work our way down. Once we get done, then we can go to the back, and this is the areas that we would listen to or oscillate on the back. So once we've assessed that airway patency and that respiratory rate and that breathing, then we have to make that determination. So what type of airway adjuncts or what type of airway interventions are we going to perform on that patient? So how we determine this, what their rate is, what their rhythm is, the quality of those respirations, and then also the depth of those respirations. So when I walk up to my patient, again, one of the first things that I'm going to assess is their airway and their breathing. So all of these things can kind of be done simultaneously or within about 30 seconds to a minute. And then based on your findings, you're going to go ahead and select what type of airway intervention that you're going to utilize for that patient. So if I walk up to my patient, their rate is good, so in between that 12 to 20, their breath sounds are adequate and clear, and they're able to speak in full sentences. You're seeing good chest rise with that patient. You're also seeing good color as far as skin condition goes, and they're breathing at a regular interval. Chances are I probably don't need to aggressively attack any type of airway intervention. Now on the right side, if I'm looking at any type of inadequate findings I'm seeing, then I might have to intervene with some type of airway intervention, whether that's oxygen therapy, assisting ventilations, or inserting an airway adjunct. So to assist or not to assist, this is in speaking of assisting somebody's ventilations utilizing a bag valve mask, a pocket mask, or if you have no equipment, you can also provide mouth-to-mouth ventilations, and that is another form of positive pressure ventilations. So the definition, positive pressure ventilation is assisting a patient with breathing through forcing air into the lungs. If that patient is not breathing adequately, this is where we have to intervene and start providing that positive pressure ventilation. If they are breathing adequately, we don't want to try and use that positive pressure ventilation. We can get away with either no interventions or by providing supplemental oxygen via non-rebreather or a nasal cannula. So here's our patient. Respiratory rate is 32. So a little bit high. That's higher than our 12 to 20 that we normally like to see. Rhythm is regular. He's forcing those breaths in, and the volume is low. So if this patient was unresponsive at this time, I could probably try and utilize that bag valve mask, because upon determining these different components, his breathing status would be classified as inadequate. Now, for a patient who is conscious, trying to assist somebody's ventilations when they are still alert or still responsive is going to be very difficult to do. Oftentimes, they will fight you tooth and nail. Now, our second patient, respiratory rate is 17. So we know that that is adequate within the 12 to 20. Our rhythm is regular, so that's good. Quality is adequate, and then also our volume is adequate. So in this case, I would probably not provide any type of positive pressure ventilation for that patient. With our third patient, respiratory rate is 2, so very slow, rhythm's irregular, inadequate quality, and our volume is also low. So this is a no-brainer where we would start to facilitate assisted ventilations using our positive pressure ventilation, either with the bag valve mask, a pocket mask, or giving mouth-to-mouth ventilations. So oftentimes you will hear less than a 6-pack or more than a case. So if their respiratory rate is less than 6 or over 24, this is where you should start thinking about assisting those ventilations. Now those are not going to, that is not a golden rule by any means, but it kind of gets you in the right ballpark. Now there are a couple of effects of positive pressure ventilation, because basically we are changing the amount of pressure that's inside their system. We're overriding it in order to provide that ventilation for that patient inside that chest cavity. So one thing that we can see and or do is that esophageal opening pressure. So there's no effect with this with normal breathing. When we breathe, that air goes by into the trachea and then in the lungs. Now with positive pressure ventilation, we can actually bypass that esophagus and then push air into the stomach. Now this is detrimental to what we do, because if we put enough air into the stomach, we're going to see gastric distension. And with gastric distension, eventually that patient is going to begin to vomit everywhere. And that's where we want to be readily available with our suction. So a good rule of thumb, whenever we're providing positive pressure ventilation, we also want to have suction capabilities readily available in the event that that patient begins to gag and vomit. Other things, again, is the differences within that pressure. So breathing instituted by that negative pressure, so we're going from positive pressure to negative pressure. Positive pressure ventilation, we're bypassing that movement and we're forcing that air into the lungs. So by forcing that air into the lungs, we are compromising the airway wall pressure a little bit. So when we're breathing adequately, there is no pressure on those walls. But with positive pressure, we are creating pressure on the air walls. So think of our lung tissue is getting an increased amount of pressure and tension on that. And then lastly, we could see changes with the cardiac output. So because of that change in pressure, we can also negatively affect the preload and the afterload of that patient's heart. So preload, remember, is the blood in. Afterload is going to be the blood out after it contracts. So different ways in order to administer positive pressure ventilations. First, very basic, if we don't have any equipment with us, we can provide mouth-to-mouth ventilations. How you do this for an adult patient is you're going to open up the patient's airway, either using that head tilt chin lift or that jaw thrust maneuver. Pinch that patient's nose closed, create a seal between your mouth and the patient's mouth, and then give enough air just to see that chest rise. That's the ultimate determination whether we're providing good, adequate ventilations, is if we can see that chest rise when we do deliver that ventilation. Another thing that we can do, we can provide ventilation utilizing a pocket mask. Excuse me. So if we don't have a bag valve mask readily available, or if we are working a cardiac arrest scene and we are the only ones on scene, this is where we're going to utilize that pocket mask. So that pocket mask is narrow portion on top, wider portion on the bottom. You place the narrow portion over the nose, wider portion underneath the bottom of the lip. Make sure that patient's airway is open. And then again, we're going to give enough air in order to see that chest rise. When we are facilitating assisted ventilations like this, so this would be the case where the patient still has a palpable pulse, we're going to breathe for an adult patient about 1 breath every 5 to 6 seconds. For our infant patients and our pediatric patients, it's about 1 breath every 3 to 5 seconds. Another thing that's nice with these pocket masks, oftentimes they will have an oxygen reservoir system on there, so you can attach oxygen tubing from your O2 tank to your pocket mask, and you're going to be given supplemental oxygen. Because if we are providing oxygen therapy to this patient right now, the oxygen content that we're delivering is actually going to be less than 21%, because we're not going to be forcing more than about 18% out of our lungs when we are doing this. And then lastly, in our go-to device that we're going to utilize for assisting ventilations is going to be our big valve mask. So creating that seal between the patient's face and the mask, very similar to that of utilizing just a pocket mask. Narrow portion is going to go over the nose, wider portion underneath the bottom of the lip. Now with that bag valve, or that bag, that is roughly 600 to 1,000 milliliters inside that bag. It only takes about 400 milliliters of air in order to make that chest rise. So be cognizant when you are performing this intervention that you're only squeezing about half the bag or just enough in order to see that chest rise. A lot of people will get overly excited and squeeze the crap out of the bag, and as a result, that excess air is going to create those negative consequences that we talked on that last previous slide. Another thing that we could see is what's called an ATV, or an automatic transport ventilator. So these are going to be utilized most often in the hospitals with a respiratory therapist, and some advanced life support agencies actually carry this on their rig as well. Nice thing is I can specifically dial into what my respiratory rate's going to be and what my tidal volume is going to be, and I can set it, and it's going to automatically provide those assisted ventilations for me. So when we're looking at the difference between inadequate positive pressure ventilations versus adequate, so when I am providing those ventilations, I want to maintain all of these numbers and all of these figures. So if I'm doing it incorrectly, or if it's not properly perfusing, I could see my respiratory rate as far as how fast or how slow I'm delivering those ventilations stagger less than 12 or less or greater than 20. If I'm not squeezing the bag enough, or if I am squeezing the bag too much, and this could be reflected upon our heart rate. So if they are not getting the oxygen they need, we could notice that their heart rate is either going to spike or it's going to drop significantly. So other tools that we can use, CPAP, and this is going to be used for the spontaneous breather who is alert and oriented and can follow commands. So this is a continuous positive airway pressure, and it is in the form of non-invasive ventilation used in the awake and spontaneously breathing patient. So this is what it looks like. It's going to create an airtight seal between the mask and the patient's face. And basically what it's doing is it's giving an extra oomph in order to get more air into the lungs when that patient does spontaneously breathe. So this is a great tool that we can use when we have a patient who's alert and oriented and can maintain their own airway, if they're breathing at greater than 25 times per minute. Because oftentimes when somebody increases their respiratory rate, it's because they're trying to get more volume in. But with that, when they increase their respiratory rate, their chest expansion usually goes down. So our signs and symptoms that we want to see prior to providing this intervention, signs and symptoms of moderate to severe respiratory distress, oftentimes associated with these disease processes, are chronic obstructive pulmonary disease, pneumonia, asthma, congestive heart failure, and then also pulmonary edema. The contraindications for using this is going to be apnea, so without breathing or no breathing, any type of altered level of consciousness, patient who's in cardiac arrest, any vomiting or anything that could compromise that patient's airway, facial trauma where we couldn't create a good seal between patient's face and the CPAP mask, and then any type of blood pressure that's less than 90. Whoa! The reason behind that is because with that increase in pressure that we're providing with the CPAP is, again, we can negatively affect that preload and that afterload of that patient's heart. Now, some special considerations when we are providing positive pressure ventilations. Excuse me. Patients who have stomas, any type of dental appliances, foreign body obstructions, facial injuries, or peds in our infants. So when we're providing positive pressure ventilations with somebody who's got a stoma, that stoma is going to be an introductory piece into their cricoid-thyroid membrane or into their neck. So our smokers or other patients who have some type of upper respiratory disease, we could see this. So we could utilize a pocket mask technique. So this rescuer's got a pediatric pocket mask with a filter piece on it, and he's able to deliver those ventilations. Now we can also utilize a pediatric pocket mask, but then attach a adult size bag valve mask to that pediatric pocket mask, and then you can perform BVMs through that stoma. And again, it's the same technique. What we're doing is trying to create a good seal and looking for that proper chest rise. Now with patients who have dentures, so when the dentures are in and they're properly seated, we can see on the patient's right that it creates a nice form so that when we are creating that seal with that bag valve mask, we can adequately do so. Now, when a patient doesn't have their dentures in, oftentimes it makes it more difficult because we're losing that facial structure in order to get that good seal. Or if the dentures are in and they are loose fitting, they can create that airway obstruction. So if they're sliding around in there, not creating a good seal, what have you, make sure that you go ahead and remove those dentures from that patient. So with oxygen therapy, there is a variety of different size tanks. D cylinders are going to be our typical size tank that we're going to see located in first in bags. E cylinders oftentimes are on the little respiratory therapist carts that you see them wheeling around the hospitals. Our M cylinders are going to be our mounted oxygen tanks inside of our ambulances. And then our G and our H cylinders oftentimes will be found inside the hospital, which are going to be our large wall-mounted tanks inside those facilities. So remember, oxygen is a drug. So every time we provide this treatment, we should be thinking of our 5 rights of drug administration, which we'll get to when we start talking about pharmacology. Indication, so any patient who's in cardiac or respiratory arrest, where we're providing positive pressure ventilation, we should always, if we can, have high flow oxygen. Any type of signs of hypoxia, so I touched on cyanosis earlier, where we have that bluish coloring of the lips and the finger beds. That should always be an indication for oxygen. If we have SpO2 capabilities, anytime they're less than 94%, we should provide them with oxygen. Or if they're complaining of difficulty breathing and showing signs of respiratory distress. So sometimes our pulse oximeters might give us a false reading. Remember not to treat the machine, but always treat your patient. Any type of medical or trauma conditions that interfere with cellular respiration. Patients who has altered mental status and you believe it's a result of hypoxia, and then an exposure to toxins as well. So for patients who have carbon monoxide poisoning, this is where it can get tricky because your pulse oximeter is probably going to say 100%, even though they were exposed to carbon monoxide. And the reason is we have a major flaw inside the human body system, and that is how much we like carbon monoxide. So our hemoglobin is going to attach to carbon monoxide 237 more times readily than oxygen. So if there is 236 oxygen molecules out there and 1 CO molecule, that CO molecule is going to bind to the hemoglobin prior to those 236 oxygen molecules. So with that, we always want to provide them high flow oxygen. Especially in our geographical area, carbon monoxide poisoning is a very common call that we're going to go on because we burn fossil fuels as for heating appliances. And then patient who is displaying signs and symptoms of shock or poor perfusion. So we have a couple of different devices that we can deliver that oxygen equipment. First, very common one that we're going to see is the non-rebreather mask. So this is the preferred pre-hospital mask. It has an oxygen reservoir bag attached to the mask with a one-way valve between that, and it prevents the patient's exhaled air from mixing with the oxygen in the reservoir so that they're continuously getting right around 90% oxygen. How we set that when we're utilizing our oxygen tank is it should be in between about 10 to 15 liters per minute, ensuring that that bag on that non-rebreather mask stays inflated. This is what it looks like. That oxygen tubing connects to that mask and then back to the oxygen tank. You notice up top, there's a little nose clasp. You can go ahead and form fit that around your patient. And then the green tags on the side, you can actually better fit that to the patient's face. Number two option that we have in every EMS protocol is going to be our nasal cannula. So this is two soft plastic tips connected by thin tubing to the main oxygen source. This is going to deliver about 24 to 44% oxygen content. We usually set this in between about 1 to 6 liters per minute on our oxygen tank. This is what it's going to look like. When it gets inserted, the prongs should be facing down, not up. So the prongs go in, should be facing basically down towards the patient's chest. Once they get inserted in the nostrils, the sides get wrapped around the patient's ears, and then that clear plastic piece right here is going to be cinched up underneath that patient's chin, so it's secured and that oxygen is going in. Try not to wrap it around the patient's head. Don't put it up because that's going to be uncomfortable for that patient, no matter what you see on Grey's Anatomy. Now, some devices that are not very common in EMS, but we could see them in the hospital setting. Simple face mask looks very similar to that of the non-rebreather mask. It's going to deliver about 60%, and it's about 6 to 10 liters per minute. So it looks very similar to that, only there's not actually a reservoir bag attached to that compared to the non-rebreather mask. Now with a partial rebreather mask, this is similar in concept, only there is a two-way valve that actually allows the patient to rebreathe some of their air. And as a result, that oxygen content is going to go down from our 90 to 100% that we see with the non-rebreather to that 35 to 60%. What we set this to is about 6 to 10 liters per minute. And this is what it looks like. So you can see up here, this is going to be our two-way valve, which allows that patient to actually rebreathe their air. Next, we can see a Venturi mask. So this is a low oxygen system, and it provides the precise amount of oxygen concentration that we want to give to the patient. So oftentimes this will be utilized inside the hospital for our patients with COPD in order to not trip that hypoxic drive. So each color code there represents a different percentage of oxygen that you can give. This is similar for the ATVs, or the automatic transport ventilators, and it's called FiO2, which is the amount of oxygen content that you're given to the patient. Another thing, many EMS agencies carry this as a trach mask. So it kind of looks like a partial rebreather mask, but it's made to form fit over a tracheostomy. So usually we're going to give about less than 50%. So this is going to go around the patient's neck, and this is going to cover that trach area. And then we can provide that high flow oxygen through that. All right, again, lab session. We're going to be diving quite a bit into our airway skills, and I'll be going over some of our advanced airways because they don't really talk about them too much in detail within your textbook. Thanks for listening, and I will see you guys at lab.